So I'm going to now introduce the Women's College part of the team, and Dr. Lisa Richardson is sitting just over here. She practices general internal medicine at the Toronto General Hospital and is the Associate Dean of Inclusion and Diversity, as well as Acting Vice Dean of Strategy at the University of Toronto's Temerty Faculty of Medicine. She's an education researcher at the Wilson Centre with a scholarly focus on how to integrate Indigenous and critical perspectives from the social sciences into medical education. Dr. Richardson is a strategic lead in Indigenous Health for Women's College Hospital, where she founded the Centre for Wise Practices in Indigenous Health. She is on council of the Royal College of Physicians and Surgeons of Canada and co-chairs the Royal College's Indigenous Health Committee. Lisa is also a founding executive member of the National Consortium for Indigenous Medical Education and belongs to the Indigenous Physicians Association of Canada. So her team, both Emily and Maxine, will be presenting. And so Emily Simmonds is a critical scholar and PhD candidate in science and technology studies at York University. As a member of the Ganishnaquday Center for Wise Practices, what was that? Ganawishkanawe Center for Wise Practices and Indigenous Health Circle, she co-leads several projects at the local and national level that support Indigenous wellness, foster accountability to communities, and advances First Nation, Inuit, and Métis data sovereignty. She's an alum of several critical justice research collectives focusing on anti-racist and anti-colonial scholarship in the humanities and social sciences, including the Technoscience Research Unit, TRU, the Digital Research Ethics Collaboratory, and the Civic Laboratory for Environmental Action and Research. So that's Emily. Maxine Brown is a mixed First Nations and settler research coordinator at the Centre for Wise Practices in Indigenous Health at Women's College Hospital. Maxine is originally from Peterborough, Ontario. She's lived in Toronto area for 7 years. She's a critical social scientist and holds a BA and MA in social anthropology from York University, where her thesis focused on an institutional policy, procedure, and discourse in academic institutions and settings. In her work, Maxine largely focuses on Indigenous data sovereignty and governance, and its operationalization in research settings, and applies rights and strength-based anti-colonial approach to her work. Her other interests are Indigenous health and wellness, education, policy, and institutional systems. Maxine is now focused on exploring and upholding the importance of collaborative research projects with Indigenous communities across Turtle Island, ensuring that the community wants and needs are at the forefront of all research, design, and implementation. So Emily and Maxine, the stage is yours.
Hi, everybody. Thanks for the introduction, Hans. Yeah, I'm sitting with the stories that Jim and Darlene shared, and Monique. So I think, the through line for me today that I hear is the need to collaborate. And I just want to point out, we've been talking a lot about the post-operative space. In 2021, Jason McIver and his collaborators released a review, a systemic review that showed that Indigenous peoples, First Nation, Inuit, Métis, across Canada have a 30% mortality rate post-surgical. So that's the landscape that we're facing. I also want to think critically together, when we talk about these numbers, what we're talking about is people's lived experiences with interlocking systems of oppression. That's sacred data. Those are people and spirits. So I think it's important to center the stories as a way to call us into our responsibilities. So I'm going to talk a little bit today about the center, Ganawishkadawe. Apologies to the language speakers, I'm still learning. I'm going to talk about our approach, our overarching approach to health system transformation and education. And I'm also going to focus on a key concept that we use called wise practices, why this approach matters, what it enables, and what it looks like at the level of practice and how it was implemented in the Coping Well project. I'm going to be joined by my colleague Maxine as well, and so I'll just see, there we go. So there's a picture of our team. I want to point out that some of our team members are here. I'm a member of a multidisciplinary team, so we cannot do this work alone. We're joined by elders, peer supports and patient advocates, as well as clinician. That photo itself features some of our internal hospital collaborators as well as some of our external collaborators. At the forefront, you see Elder Cindy Wright. So as part of the center, we have 3 arms to the center. We have an educational arm, and we have a clinical arm where people can access Indigenous traditional medicine as part of their care experiences. And we have a research arm as well. Somebody mentioned ECHO earlier. We're one of the first hospitals, I think, in the GTA where if an Indigenous patient comes in and self-identifies, they can receive a referral into the Indigenous clinic that's run by Elder Cindy White as well as Christine Montenegro, like they would any other service, okay? So that also is a very clear signal about the fact that traditional ceremonial practices are as important and as necessary for community members to access as biomedical forms of care. So I'll give you a little bit of perspective. We're located at Women's College Hospital. We're a place for education, advocacy, traditional healing, clinical care, and Indigenous scholarship. The center is a multidisciplinary team, as I mentioned, and our overarching goal is to ensure that First Nations, Inuit, and Métis communities across the territories receive quality care. So I'm going to talk a little bit about our overarching approach and why this matters and how this might pull apart from other approaches to research or education or collaboration. We use a rights-based approach, as Darlene mentioned, in the OCAP principles, which anyone that has ever partnered with community has probably said, great, OCAP, and placed it into their research design. But you know, there's a lot of back and forth and discussion about what that looks like at implementation. And it looks different in every community-led project. But we lead with a rights-based approach that upholds the sovereignty of First Nations, Inuit, and Métis people, okay? So a rights-based approach to healthcare education revolves around recognizing and upholding First Nations, Inuit, and Métis people's inherent right to health as established in various international agreements, including the United Nations Declaration of Rights of Indigenous People, as well as the obligations that are collectively outlined by the treaties. A rights-based approach to health education is not only essential for promoting health equity and respecting Indigenous self-determination, but also addressing the ongoing historical injustices and advancing reconciliation in the healthcare sector. Such an approach can also drive innovation. So I think there's a way that we talk about centering community as if we're only the community benefits, but I actually see this as a two-way street. So fostering community-centered approaches, integrating traditional healing practices, and promoting cross-sector collaboration, and encourages responsive policy and programming design that reflects local and regional community-centered priorities. One example that was shared with me when I was in community was, you know, the rematriation of the local fish population and how central that was for health, right? So we think about access to traditional foods, controlled land stewardship. So this is an example of like what a sort of cross-sector collaboration could look like. We also saw a mobile health clinic, so clinics that were going out into community. So again, this cross-sector approach that really drives innovation and makes sure that the programs and policies that we're putting in place actually are meeting the needs and the priorities as determined by those communities. So how do we apply a rights-based approach in health education? What are the tools that we can use or the frameworks that can enable us to take on this work? Here I've held up a quote about wise practices, and so I'm going to give you a bit of an overview of what this is. We apply this approach in practice by using a concept of wise practices, which the quote from scholar and educator Dr. Vinya Kirkness, a Cree scholar, on the slide highlights the potential and purpose of the concept. We can see from our quote that the gift of wise practices is that it respects Indigenous knowledge systems and the integrity of that, and it also allows us to work with Western paradigms as well. So in essence, wise practices allows for multi-paradigmatic understandings to research and to education. The concept of wise practices can be used to promote a rights-based approach to health education by prioritizing community definitions of well-being. So we're not starting from a biomedical lens. We wanted to go to community and say, like, what does it mean to be well? What does that look like? How is that practiced in the everyday? So we understood that, like, health is not a fixed status, but something that's practiced. And I think for us, shifting the aperture away from a biomedical definition allowed us to really hear how the cultural definition of well-being was very specific to an Anishinaabe community, which could look different for somebody like me who's Métis or Maxine from a different First Nation. So I think, attending to the specificity of concepts of wellness is key for designing educational resources that both resonate for community members, but also acknowledge the specificity of the differences across our nations and communities. The gift about wise practice is that it prioritizes cultural safety by acknowledging the value of Indigenous healing and wellness practices. Overall, the utility of the concept is that it recognizes the importance of contextualizing health research and education within the cultural and historical experiences of First Nations, Inuit, and Métis people, whereas traditional Western approaches to education and research may overlook or minimize the significance of the socio-political and cultural factors. Wise practices not only involve addressing the symptoms of the illness or the prevalence of a condition, but also considers the root causes and the broader socioeconomic political factors, including how epistemic racism, which is the way that racism operates at the level of knowledge production, by delimiting what is considered valid, authoritative, or true within academic, scientific, and cultural contexts, contributes to ongoing health disparities. So what are some of the structural factors that are shaping community health outcomes for First Nations, Inuit, Métis people? We heard about the impact of these factors, both from Jim's story, Monique's story, and the importance of upholding traditional Indigenous governance systems from Darlene. So I'm just going to identify some of the factors. Colonialism, I want to point out, is not a historical event or a political artifact. It is a mode of relating and a system of governance that continues to shape the current state of relationship between First Nations, Inuit, and Métis peoples and healthcare systems. Not just how we enter these systems, but probably at point of care too. Colonial policies and practices have a profound and enduring impact on Indigenous health outcomes. Here are several ways in which colonialism continues to affect Indigenous health. Forced displacement and loss of land. We don't talk about actually, in most health models, the connection between land-body relations, but we heard the importance of ceremony and place-specific ceremony when we were in community, and having access to land and being able to practice those ceremonies and protocols. So when we think about the displacement and the dispossession, it's not just that it was the land was taken, it was that the practices that historically and traditionally promoted health and well-being, which were land-based, could no longer be practiced. Of course, forced assimilation policies and the legacy of the residential, and I hate to call them schools, I think industrial camps or day schools is more appropriate, with the forced removal of children from their families and communities. And I want to just flag here for those that are not aware, the last residential school closed in 1996, so people my age survived the residential school system. Underinvestment in healthcare, I think that's a generous description. We have to remember part of that sort of assimilation practices and policies that were in place, the healthcare system played a role in that, both through the nutritional experiments that were run in residential school, as well as the Indian hospital system. Again, cultural disruption and discrimination, we have to remember that when people have the right to practice their ceremonial protocols and traditions, that this was not just banned, but criminalized in Canada. And we hear healthcare system bias and anti-Indigenous racism, which we didn't have to lead with those questions when we listened to community. They were right at the surface. So we didn't have to ask very far after what does it mean to be well. Followed by that was, what does it mean to access healthcare services? And so that was like the predominant thing that was named, was the experience of racism and discrimination at point of care. Of course, we see this in the news through Joyce Echaquan and Brian Sinclair. Addressing these issues requires a comprehensive approach that recognizes and respects Indigenous rights, culture, and uplifts self-determination. This includes investing in education that promotes access to culturally safe healthcare services, addresses systemic racism and discrimination, and supports Indigenous led healthcare initiatives, and promotes partnership between Indigenous communities and healthcare providers. So I'm just going to shift now. That's some of the factors that are structuring the current state of relationship. And I'm just going to quickly go through some of the principles of what wise practice looks like, so the foundation of this concept we're talking about. The concept of wise practice in the field of health education and research has roots in Indigenous knowledge systems. So again, it's not about saying this is the right approach, this system matters, this doesn't matter, this is the right way to look at chronic pain. It allows for, again, multiple understandings to come into play. And we heard today throughout the talks that, like, the importance of multimodality or multi-therapeutic. So it's the same thing here. It's the same principle that I think is substantiated by the medical evidence. Same thing here, right? But this time the therapeutic includes cultural practices and ceremonies. So community-driven collaboration is the key to the practicing wise practices. So we don't go into community and set the priorities as knowledge workers. We understand and respect the community knows their priorities and needs, and so it's a little bit of an inversion from how typically Western research is done, where perhaps the person coming in is the expert. Instead, we recognize and respect community as the expert, and we're coming in with our toolkit. Holistic, again, we were reminded that many people in community had very holistic understanding of health. So it wasn't, mind, body. It wasn't emotion, body. It was mind, body, heart, spirit, which was quite different than what we see. I think there was a gentleman that asked earlier to the team of, I believe, psychologists about the importance of prayer, and was that a factor in terms of thinking about managing, coping well, or living well with pain? And absolutely, we heard that ceremony and connection helped folks to live well with pain. Again, wise practices adheres to the ethical guidelines outlined that prioritize the data sovereignty and rights of community, and that really, at the end of the day, it's about a form of collaboration that acknowledges that community often has the solutions but lacks the resourcing. So how do we come in and support those needs that have been identified by that community? So with that, I'm going to pass it to my colleague, Maxine.
Thanks, Emily. Now I'd like to speak a little bit about what a strengths-based approach is and how it was applied in the context of this project. So the relationship between wise practices and strengths-based approaches lies in their shared emphasis on holistic well-being, cultural relevance, and community empowerment. By integrating wise practices into Indigenous health education, educators can draw on traditional knowledge and community resources to promote health. Strengths-based approaches complement wise practices by recognizing and nurturing the strengths and assets within Indigenous communities, honoring the right to self-determination. In essence, wise practices provide a framework for culturally relevant and holistic health education, while strengths-based approaches amplify the inherent strengths of Indigenous communities, resulting in more meaningful, effective, and sustainable health interventions. So, a strengths-based approach is essential for the pursuit of health equity. However, a deficit-based approach is more frequently present in health professions education, health communications, and practice. A strengths-based approach considers the whole person, including the socio-political and cultural factors that shape people's experiences and health, with a focus on the individual's strengths and abilities. Strengths-based approaches understand the individual as the expert of their own experience, with valuable forms of self-knowledge along with community and cultural knowledge systems. Strengths-based approaches often focus on the idea of wellness rather than strictly health as it is understood in Western biomedical models, and holds space for subjective understandings and embodiments of wellness. This model also rejects top-down approaches to intervention and highlights principles of co-creation, which flip conventional conceptualizations of who is and can be the expert. Conversely, deficit-based communications and narratives highlight the lack of something and aim to identify failures and insufficiencies to be remedied through healthcare intervention. The deficit-based model is rooted in colonial thought and systems and often places blame upon the individual for their perceived failures and insufficiencies, while imposing a top-down approach to intervention that views the researcher or scientist as the expert and the individual as the target or subject of intervention. Deficit-based approaches often have narrowly defined conceptualizations of health, that which exists by standards and understandings of Western biomedicine, and often fails to expand its definitions into differing pedagogies and epistemologies. Focusing solely on deficits facilitates harmful practices and beliefs, often resulting in unfairly and inaccurately blaming Indigenous peoples for poor health outcomes or chronic and acute conditions, which we know are most often a result of broader historical and current social systems of inequity and inequality. So, within the context of this project, a strengths-based approach recognizes a way of understanding that community members from Treaty 3 territory have strategies grounded in community and culture for managing chronic pain and pursuing health and wellness. In taking a strengths-based approach to this project, we center the various experiences, stories, narratives, and forms of self-knowledge that community members brought forth and reject the deficit approach that has so widely been applied. So although a strengths-based approach is being more widely spoken about in relevant literature, there often exists a gap of what this looks like at the level of practice and how it's operationalized in research and quality improvement projects. Like principles of Indigenous data sovereignty, engaging methods of a strengths-based approach to research isn't embodied in a universal application. Applied strengths-based approaches will look and be applied differently and requires introspective consideration along with often community consultation for its application. At the level of practice in this project, a strengths-based approach grounded the foundation of all phases of our work, and we'd like to speak a little bit about the knowledge gathering phase. So the language of knowledge gathering is used in this project's context as a means for further upholding and acknowledging the experiences and stories shared by and in community as valuable knowledge. This discursive practice also challenges forms of epistemic racism that shape what is understood as knowledge and who can be an expert. So one space in which the strengths-based approach can be seen within the knowledge gathering phase was throughout the discussion questions that were formulated by the project team. The questions that we as facilitators asked to community didn't rely on the deficit approach that is so pervasively applied in projects with Indigenous communities. Rather, the framing of our questions aimed to generate greater understanding of First Nations community members' strategies for wellness, despite living with chronic pain, and what it means to live and be well with pain, starting with meaning-making practices to identify what wellness means and looks like. Some examples of this in our discussion guide were posing questions such as, what does living well mean to you? And what are your personal or community strategies for living well? The direct and specific focus upon wellness in our discussion guide and conversations with community members was an active and intentional decision made by the project team. The strengths-based approach to knowledge gathering in this case allows the deficit model to be flipped or inverted, enabling the involved community members to be invited to speak about what their journeys to wellness look like and how they personally live well with their chronic pain, rather than what one needs to fix or pointing to unfounded individual failures. Doing so allows for the upholding and honoring of First Nations community members' journeys to and embodiments of wellness, and the engagement of community members as active and crucial partners of the project process, rather than passive subjects. Using the gathered knowledge from the community members, we were able to create educational resources to support community in their journeys to wellness and provide education to healthcare providers and physicians on First Nations specific experiences in receiving chronic pain care that refuse top-down forms of intervention, which pose the researcher or scientist as the ultimate expert of the lived experience. All resources were created directly in response to the stories, experiences, and narratives shared in community by community and were not interpreted, therefore further acknowledging the community members as the experts of their embodied experiences. The co-creation of the resources through a strengths-based approach allows for the refusal of the pervasive top-down model to educational intervention and instead allows the resources to be grounded in community experience, strength, ability, and knowledge. So what are some of the key takeaways? Applying or engaging the concept of WISE practices to projects with Indigenous communities allows researchers, practitioners, and educators to contribute to advancements of Indigenous health and work towards addressing gaps in health conditions and outcomes for Indigenous peoples in a socio-culturally responsive and ethical manner. The engagement and application of WISE practices is contingent upon meaningful partnerships across all phases of project work. Partnership and collaboration therefore exist as primary principles to enable the engagement of WISE practices. And in taking a strengths-based approach to a given project, the project team works towards ensuring that the created resources resonate with the realities and experiences of those who they are intended to support. Thank you.